To introduce the next speaker is Dr.Bancha Chernchujit from Thailand. He is a professor in orthopedic surgery, Faculty of Medicine, Thammasat University of Thailand, right? So he's going to give a talk on the how to deal with short graft, short tunnel in ACL reconstructions among Asian people, which is a very, very common problems in Asia. So Bancha,
yes,
are you ready?
Hi, I'm
Good.
ready.
Thank you. We hand over the microphone to you, right?
Thank you. Thank you, Patrick. Thank you, David, and ISAKOS-APKASS team for inviting me to this wonderful ACL symposium. I'm Dr.Bancha Chernchujit from Thammasat University, Thailand. So I'm talking about the topics how to deal with short graft, short tunnel in ACL reconstruction among Asian people. So this is our major problem, the short graft, short tunnel in ACL reconstruction. So the Western, maybe you didn't have this problem because this is a major problem in Asian people. Although we are short, we are small, but inside we are not small. You understand? That means our ACL also strong and big, okay? So the short graft actually is more challenging in PCL reconstruction. I got this concept from PCL reconstruction. So in PCL reconstruction, I always have problem because our graft always short and slim. I need to make it big. So I use the aperture fixation. I use the screw close to the joint. So I apply this technique from PCL reconstruction to do it for ACL reconstruction. Okay. So this technique works very well for the patient that have very short tunnel and short graft. Okay. We put the screw close to the joint like that. So this is a study from Dr.Freddie. He found that the average femoral tunnel is around 35, but in Asian people, this femoral tunnel is less than that. For my study, it's about 31. Okay, it's shorter, and also this femoral tunnel was correlated with the height of the patients. And the tibial tunnel is more variable. It depending on the knee morphologies and also the aiming device that you perform. This is a study from Singapore. They found that the average diameter of the female is only 7. In male is about 8 for the quadruple reconstruction. So I think 7 is not enough. Yeah, you cannot get good result from 7. So let's go to the technique. This is my patient position. I put the patient at the end of the table, break the table and drop the knee down 90 degrees. And then we use minimally invasive, arthroscopic assisted, hamstring. I use both semi-T and gasless. We use the unequal limb. Sometimes it's very short, so you can see the pictures. Yeah, we make it unequal like that. And finally, we make it big graft. Our shortest is 6 centimeters, and average diameter is about 9. Most of the time, it's about 10. So you need to have a very precise calculation for the femoral tunnel. My shortest tunnel is 12. Intraarticular part is about 23. For the tibial tunnel, it's about 25. This is for the 6 centimeters. So for the daughter side morbidities, comparing the semi-T alone and the semi-T gases, there's many articles found that there's no difference. Also, this article found that there's no difference. You take 1 or 2 tendon, the result of the donor side morbidity is the same. So this technique, remnant preservation, is very popular in Asia. Why? Because our Asian size, the ACL is small. So that's why Japanese people or Korean or China, they prefer this technique because you can make a bigger graft. You can see from the right, you see that? If we preserve this remnant together with our graft, our healing ACL would be bigger. And also this remnant would make the side-to-side vascularity. You have better healing and you can have a bigger graft. Okay, so I prefer the remnant preservation if you have remnant left. So in conclusion, for the short graft solutions, I use the remnant preservation if that remnant exists. We harvest both semi-T and gasless. We use the every millimeters of the tendons. Okay, if the tendon is too short, we can use an unequal fold. Okay, like this. And also we secure the graft, heavy sutures around the graft, wrap around the graft, because this you can prevent the damage of the screw when you put the screw in. So another problem is a short femoral tunnel. You can do the deep flexion like this, you can increase the femoral tunnel, okay? And nowadays we have a very good adjustable loop. Because adjustable loop, you can do the fine tune. If you use a button loop, it's jump every 5 millimeters, okay? So you have a thicker cortex using this adjustable loop. And my graft in the tunnel is only 12 to 15 millimeters for the short patients. Yeah, this is an example of this adjustable loop. Okay, you put this button in, and then you slowly put the graft in. So this button is blind, right? You're not overing, okay? And you can do the fine tune. And your graft size, I recommend to have a press fit because you have less gap between the bone and the graft. You may have the better healing, okay? So that is for the femoral tunnel. So what is the shortest length of the femoral tunnel? We did the study, okay? We did the short graft femoral tunnel ACL reconstruction, critical and functional outcome. We comparing the more than 15 millimeters and the less than 15 millimeters, okay? The result, we found that there's no difference, okay, in knee stability also, and also the functional score. So less than 15 and more than 15, that's the result is the same, okay? So that's the conclusion of our article. So this is a solution for short femoral tunnel, okay? Number one, you do the deep fractions to get a longer tunnel. You use adjustable loop, 15 millimeters or less than that is enough. Okay, my shortest is 12. And you did the press fit femoral tunnel, use adjustable loop. Okay, so that is the solution for the short femoral tunnel. For the tibial tunnel is another problem. Okay, you see this patient, they have short tibial tunnel because nowadays our ACL, we put the tunnel more anatomic. That means we put it more anterior. So when you make a tunnel, it's always like this. And when you put the screw, sometimes the screw is prominent and the patient has painful. And some the screw is loose because this bone quality is not good. Sometimes you break the anterior cortex, like the left one, in the middle one. So I prefer to use the posterior screw for the ACL. So the posterior, you can have a longer tunnel, okay? And I prefer to make it more steep, like 65 degrees. I can have about 4 centimeters tibial tunnel, okay? And put it more central, okay, like that way, okay? So that is a solution for the short tibial tunnel. I make the tibial tunnel steeper, and also we make a sequential reaming that way and put the screw posteriorly. So that is the solution for the short tibial tunnel. And always read the scale. You can know that what is your tibial tunnel length. Always read the scale, okay, and precisely calculation. So this is another trick. I put the guide in first, okay, before passing the graft. I put my guide posterolateral. You put the guide in first, so that will not injure your graft. You see that? I put the guide in and then followed by the graft. So you can never cut the graft, because if you put the guide later, sometimes the guide pin getting into the graft and you turn the screw, you cut the graft. Okay. So this technique, I never cut the graft. Okay. So that is another trick for the guide wire pinning, and you can guarantee that your screw is in the posterior. And I prefer to use a longer screw because the short tunnel, I can make the nearly like bicortical fixation. I always use 35 millimeters. So it's you fix both cortex, the near cortex, and also close to the aperture. So that make your fixation better. You can see from this X-ray MRI, you can see the anterior screw, you put the graft posteriorly and make the graft more vertical. And sometimes you impinge, make the graft impinge to the lateral condyle. So if you put the screw posteriorly from the right side, you can see that ACL look very nice, look very native. Okay, this is our techniques published in the arthroscopy journal. Okay, we found that using this technique, you have less problem about the lateral condyle impingement, and your graft is more anatomic and more oblique. Okay, so this is the solutions for the short tibial tunnel. Number one, you make a vertical tibial tunnel. Okay, I prefer 65, and the tunnel is about 4 centimeters. Measure the length of the tibia every time, because you need to have the very precise calculation, and put the longer screw. And this screw, put it posterolateral. not anterior, okay? Like this one, you put the guide in and then you put the screw, follow that. The screw will be posterolateral, okay? So post-op, we immobilize the patient in full extension, quadricep exercise right away, okay? It's 1 week, make sure that the patient has no flexion contracture, okay? And 3 months, okay? This is a post-op x-ray. You see that this ACL, even she's very short, she have very nice ACL graft after surgery. And the screw is posterior, okay? Posterolateral, okay? And this is a clinical outcome from our study. We found that our score and also the function after surgery is quite good. And this is our study. It's going to publish. We found that the posterolateral screw increase the graft obliquity in sagittal view and also make the tunnel longer and make the graft more anatomic comparing to the native ACL, okay? So this patient, she is very small. She has a combined ACL and PCL injury. So you can use this short hamstring from both sides. So you see that the tunnel is less than 30, okay? So we make an ACL reconstructions together with the PCL reconstruction, okay? And we use a transseptal technique for the PCL reconstruction, put the graft in, okay? We should have very strong assistance. So you need to put the graft very press fit in the femoral tunnel, make sure that the front button flip nicely. See? You see that this is the button in the femoral tunnel, okay? Yeah. And then we drag the graft in, okay, like that way. So this is an adjustable loop. It's quite nice for the short tunnel, short graft patients, okay? So this ACL and PCL reconstruction at the same time, okay? And the patient have very good results after that, okay? And you see that this is the post-op screw. You see the screw is very close to the joint, PCL and ACL, okay? And this is 3 months after surgery. The patient have good stability and she has a better motion. So this is a take-home message. For the short tunnel, short graft, we need to have to do the customized ACL reconstruction. It's not like the routine ACL reconstruction, okay? Keep in mind. For the short femoral tunnel, my solution is I put the graft in less than 15 millimeters. I use an adjustable loop. I use a press fit tunnel. For the short graft, we harvest both semi-T and gaseous. We use an equal limb technique and also we preserve the remnant. For the short tibial tunnel, I use a vertical tibial tunnel, 65 degrees. We use a longer screw, bicortical fixation, and I put the screw posterolateral to push the graft to anteromedial. That is more.
ISAKOS is very proud to support the combined APKASS problem meeting next year in Pattaya Beach, Thailand. It's going to be a wonderful international collaboration with nearly 100 invited speakers. I encourage you all to come and join us for a wonderful event.
Ladies and gentlemen, I'm Ryosuke, the president of APKASS 2020, Dr. So please see you there. Join us.
Hi, my name is Nobuo Adachi from Hiroshima, Japan. I'm current president of Japanese Orthopedic Society of Knee Arthroscopy and Sports Medicine. I'm really looking forward to attending the next COSSM and the APKASS combined meeting in Pattaya 2020. Let's get together.
Okay, and also we have a P-course on the 2nd. This is the irreparable rotator cuff tear course. Okay, we have the Teru Mihata, we have Dr. Eriksson, and we have this Pascal below. This is the 3 musketeer in massive rotator cuff. See you again in Thailand. 3 to 5 December. Thank you.
Thank you, Bancha, for that excellent presentation. And we're now moving on to our final speaker, so Professor Karl Eriksson from the Karolinska Institute in Stockholm in Sweden. And Karl is also the chair of the ISAKOS Knee Committee. And Karl is going to talk to us about biological considerations in ACL reconstruction. Thank you, Karl.